with the advent of CT in most facilities, we tend to use that a lot, minus the chest x-ray, because everybody gets that. But it is important. We'll cover mostly plain films in this lecture, and it is still useful because I think I said it before. Like at your roll 2 is the only thing you have. Most of them don't even have ultrasounds yet unless they convince the unit to buy it. So all you have are some plain films, and you have a X-ray tech. Sometimes you'll have a doctor. Like I know I didn't have a doctor when I was at the roll 2. So you have to read all your films on a little like old 1998 tough book that's this big. That's what it connects to. So it is important to understand how to use plain films because it might be the only thing you have it sometimes. So it's important to understand the different uses. However, some of them have fallen out of favor. But when we're talking about fractures, it is a very great tool to use. Let's see if this is going to work. All right. So here's what we're going to talk about today. And we're going to talk about x-rays, and I just want to clarify some things about yesterday with the chest x-ray. The chest x-ray is the king. The most ordered test in medicine. You guys are going to order it every day. Like they don't have like numbers on it, but like at least a quarter of all patients treated get a chest x-ray. All the traumas get a chest x-ray. You're going to get it on all of your any sort of lung conditions, but you can find pneumonia, pneumothorax, any type of infection with it, emphysema, cancer, heart conditions like heart failure, tamponade, aortic injuries, chest wall injuries, rib fractures, subcutaneous emphysema, pneumomediastinum. So it is a good indicator. It might not be the best study, but there are subtle indicators on there that can lead you down a path to a diagnosis. And it's so readily available and easy to get. That's why we like to use the chest x-ray. So it is important. You guys order it probably the most in your careers. And it's important you guys look at all of them as well when you're after you order them. So don't get in the habit of just looking at the radiology report because they can sometimes be wrong. And a lot of times you're not putting in where that pain is because we're ordering it fast or a triage. So the radiologist might not know what you're looking for, but you do. So that's why it's important you guys look at your own studies, okay? We'll talk about CT, which is an adjunct to the secondary survey. Then we'll go over some ultrasound. All right, so like I said, initial imaging, chest x-ray. Everybody gets portable chest x-ray. Blunt trauma, penetrating trauma, even if we don't know that they had trauma but think they did, we're going to order a chest x-ray. And obviously we're looking for, pneumothorax, any sort of rib fractures, hemothorax, diaphragm injuries. You can look at any sort of trochanteobrachial injuries, any aortic injuries. Now, it's not the best study for those, so you can't rule them out with it, but it is a great screening tool because it will identify any of those or most of those injuries as long as they're to a certain extent. So like you have to have that takes 300 milliliters of fluid before you're going to see an effusion or anything like that, and it blunts the CPA, but it is a great tool to have on hand. So if it comes back normal at that point, you can't rule it out, but it does give you a good indicator. He's probably not bleeding in his chest anywhere, so why is this patient unstable? And then we have our CT, which is going to be something especially useful for our blunt trauma patients. But a lot of the patients, if they're stable, will get a CT just to rule everything out. But blunt is usually our biggest concern because they can have so many concomitant injuries with those. CT is very helpful. All right, so everybody remember this kind of kills me because like everything has an A, B, C, D, E, F mnemonic with it, but obviously they have one with the lungs that we're going to go through. We also have one for the spine, one for obviously our primary survey. What else do we have? A, B, C, D, E, F for basically everything in medicine. So first thing we're looking at is our lung markings. This is just looking at it for any airspace disease, and it should look fluffy, cloud-like, hazy. We're looking at our pulmonary vasculature, and that's really what everything other than our soft tissues, bones, and heart are on there. So we're looking for anything abnormal in there. You can see interstitial disease look like little particles. Then we need to check the bones, which is important. Another key thing to think about, especially with trauma patients, is usually we get a PA and a lateral for a chest x-ray. For trauma, it's going to be an AP because typically we can't have the patient, stand against a wall appropriately. So it actually changes a little bit of the angle on there. So Your cardiothoracic size might be a little bigger, so you're not really, this makes it a little harder to say, oh yeah, he's got cardiomegaly because of the way it's shot. If you guys understand, when the plate is behind you and the heart is in the anterior portion, it's going to make the heart look larger. If you're looking at, it's like a shadow almost when you're taking that picture, so it's going to look a little bit larger. That's why it's sometimes a little different. So we do need to identify whether it's AB versus PA when we're evaluating these. All right, and then we're looking for any densities. So obviously when any fluid is substituted for air in the lung, it's going to look white on our x-rays. We want to look at our hemidiaphragms, the right side, because the liver is going to be a little higher than the left side. And then we're looking for any sort of effusions or any fluid in there. Foreign bodies, like if we have, and if we've intubated them, we want to check the position of our ET to make sure it's at the carina, it's not right main stem. We need to look for any, if we have like an NG tube or any other central lines, chest tubes. We need to look at those interventions and assess whether they're appropriately placed. Then we look at our great vessels, gastric bubble. We want to check our hyla, mediastinum. And then we want to give our overall impression for this chest x-ray, which this is a normal chest x-ray. And now we'll start with the abnormals. What do we see on this one here? I know that the slide says it on there, but you guys see where the line is, like that visceral pleural line that we like to talk about? Can I get a yes? Maybe? No? Everybody sees like you got that line kind of collapsed in there and it looks darker afterwards, and you don't see any of those vascular markings that you would normally see. So that's obviously indicative of a pneumothorax. Is it showing on? Let's see. So other things that you're going to look for, any sort of subcutaneous emphysema, obviously any sort of any tension physiology, and then they can have a deep sulcus sign. It looks like there's some, did you guys say some fluid in there on that right side as well? Yeah, it looks like we got blunting of the CPA, and it almost looks like some pooling there on the bottom, like meniscoid type shape for that x-ray. You guys see any rib fractures on there? What's causing this? The left, yeah, the left is higher than the right. We're almost the same height as right, which is abnormal, right? Because the right should be a little bit higher. So that's another indicator, like we were saying, when you're reading the whole chest x-ray, you want to look at all those features on there. You see, where do we have a fracture? I know I saw one earlier. It's not very visible on here. And then we have our CT scan there on the bottom right. That is obviously a lot better test, but typically not indicated if they have especially a tension pneumothorax. We need to treat that prior to getting a CT scan. Now, if they're stable, sometimes we look at a CT scan to try to identify how large it is. And we have our hemothorax, that's blood in there. And obviously very visible on this x-ray, so we have blood in there. They're definitely going to need a chest tube. Now, it depends, obviously in trauma, that's certainly the case. Now, if it's malignancy, we may have to work them up a little bit further. We may get that CT scan. Just because when it's malignancy, a lot of times their body, they've slowly developed those, they might have slowly developed that. And so they tend to be stable. All right, what do we see here? There's definitely some fluid there at the costophrenic angle. What else? Yeah, he's got a right-sided chest tube. And what do we look at when we're evaluating these, like for the chest tubes? You guys know? Yeah, we're looking at a radio opaque line, but we want to make sure those fenestrations of the holes are actually into the chest. So a lot of times, not a lot of times, sometimes people won't have, and depending on the patient's body habit is, these are gonna let air in, so sometimes you have to make sure that they are actually through the soft tissue there, so if you see those holes, this one only has one, which is kind of atypical, usually you have more than one hole in that tube, but what else you guys see on this, other than that chest tube? Yep, okay. You got a good gastric bubble. Looks like there's some rib fractures there. What else? And what are some other like subtle indicators that it may not be obvious if you see a rib fracture or a pneumothorax, but all this subcutaneous emphysema, that's a lot of it, so it's hard to miss that. But a lot of times, there might be just a subtle or small amount there, and you may not notice a rib fracture or pneumothorax or anything else, but that would be a subtle indicator that maybe there's something else going on, and you need to look a little bit better, or maybe order, if they're stable, a CT scan or another test so you can further evaluate this. Oh yeah, that's what I was talking about, subcutaneous emphysema. So you're just, basically air in the soft tissues, and it can be anywhere from the neck, chest, abdominal walls, and it typically like dissects along muscle bundles. Sometimes you'll see like almost like a straight line of air within those soft tissues of the chest. And you can also get it from like tracheobronchial injuries as well. Esophageal injuries are definitely severe, so if you see that, you need to get real worried if you suspect esophageal injuries. You can see pneumomediastinum as well. I had I don't know, he was like a 19-year-old out on a demo range. He didn't tell me this, obviously, and he came in for sick call on Monday, that was Friday, and he had like flu-like symptoms, but he was a little hypoxic. He was febrile, so I was like, oh, he's sick, and I got a chest x-ray. He had pneumomediastinum, so he had a bunch of air in there. And the radiologist called me and was like, hey, what's up with this dude? He's put like rule out pneumonia. He's got air everywhere, and I was like, oh man, let me call this guy. And he was like, oh yeah. I was like, what were you doing? Like, what happened? And I thought maybe he was coughing real hard, some sort of like minor trauma. And he was like, I was like, were you out like with explosives or anything recently? Did you do anything crazy? He was like, oh, it was on a demo range on Friday when it started, and I was like, oh, there we go. You don't do anything with it. Just I don't think there's some oxygen, get a CT scan, monitor, but still, it was just interesting. I wasn't expecting that kind of finding on the chest x-ray, but he had air in the mediastinum, and then it also tracked subcutaneous emphysema in the neck as well. So, and supposing I palpated his neck, I might have felt it, but it's neither here nor there. All right, pleural effusions, so they can obviously have different appearances, and we talked about it more commonly with a lot of our malignancies. So we're not gonna, go over it again because we're focusing more on trauma here, but obviously like a hemothorax can be, one of these effusions as well, so it's something we need to discuss, but typically it's gonna have that whited out appearance. You're gonna have that meniscus sign is very common when you have these. And these ones in trauma are going to get a chest tube. You can also have a hemopneumothorax, so you can have both in there, air and fluid in the hemithorax. And that's where it can kind of trick you because you don't have that meniscoid sharp line on there. And our good old diaphragmatic rupture. So, like we said last time, most common on the left side. You can have that diaphragm rupture typically associated with some sort of blunt trauma. And these ones can be kind of difficult, especially, I don't know that. I guess if you have the right history, obviously something is wrong in that image to help guide you down that path. But, what else would you think that might be other than that giant gastric bubble in the lung? It's kind of tricky looking, right? Would you guys, if you didn't know this, think like, oh yeah, especially if it was like some minor blunt trauma, you're like, maybe that's blood, maybe he's got an effusion, I don't know. So sometimes that's why these can trick you. Once you know that it's the gastric bubble. And the reason I say it is when you read tons of x-rays, there's a lot of like subtle findings that you may overlook, especially that one is a little more obvious, but there are some that aren't as obvious. That's why we like to put that NG tube down to help us with this diagnosis. So if we're suspecting it, or if we get this x-ray, we'll likely throw an NG tube down, one, to decompress the stomach and help reinflate those lungs, and then two, it'll help give us an idea that they have some sort of rupture there of their diaphragm. And these are all going to require surgery to repair them. And then we got our widened mediastinum. So this is like where our descending aorta is, and it's obviously an indicator that there may be some sort of thoracic aortic injury, especially with a history of trauma. It's also something we always like to look for without a history of trauma, just for any dissection that may not be traumatic related. I have, there's also some other signs that we talked about yesterday, like loss of that aortic knob. So I got a quick video I'll show you all that he explains it pretty well on what it does and how to identify it. It's probably going to block me. Hang on. I had it pulled up, but we'll see. Yeah. You guys ever have to use the Recore Wi-Fi to go?
Loss of the aortic knuckle, and in the left there's the so-called apical claw cap. As the balance due to the injury, we load foot meters on space and then track superficial to the parietal pleura into the apical space, the so-called apical claw cap. In the case of aortic transection, the bullet that is in the mediastinal space widens the mediastinum and then tracks superficial to the parietal pleura, which is the green structure, and forms the so-called apical claw cap.
All right. Not the best video. Both of them is the same. You want to control that blood pressure and heart rate with a beta blocker. Typically, we use esmolol because it's fast on, fast off, but there are other options if we don't have esmolol. All right, and then the good old C-spine, right? We're gonna, most of these especially blunt trauma patients, or depending on the mechanism, most patients are gonna come in with a C-collar on, so, around 5%, tend to have some sort of C-spine injury involving the neck with trauma. So that's why we like to use our systematic approach. We have a C-collar on them, and then typically we don't take that off until we clear the C-spine, and that's usually with the CT scan. And then there are certain criteria we use to clear the C-spine, like they don't have any spinous process tenderness on palpation. They're able to you have full range of motion of the neck, and then obviously your imaging is cleared. So those are like mostly the guidelines we use to clear the C-spine after evaluation. But here's our lateral C-spine. So this is a plain film. Typically, we don't use a plain film to clear the C-spine. We do use plain films, however, the neurosurgeon or the ortho spine doctor does. And this is how they monitor it like every other fracture. So they'll take serial x-rays throughout whatever condition they have, whether it's a fracture or whatever they're suspecting, until they can demonstrate healing on these patients. So, but I mean, the bottom line, when you're looking at these, you want to make sure you can see the C7-T1 interspace. If not, then you probably need to get a repeat image. Then you just want to look for normal curvature. You want to look for any step deformities, check the disc spacing, symmetry, and then any soft tissue edema. We usually have a little mnemonic, like 6 at 2, 22 at 6 is how I remember those little soft tissue edema things, or a little mnemonic for the radiographic evidence on that. But for trauma, we're typically getting that CT for a better evaluation. Sometimes, like for that soft tissue edema, which is unrelated to this, like if we're worried about some sort of like retropharyngeal abscess or infection. That's a lot of times why we would get a lateral, or why I do an ER anyway for a lateral. And that's when that 6-2, 22-6 comes in handy, looking for any sort of like retropharyngeal abscess. And the reason we do an x-ray most of the time I do it is because it's in pediatric populations, we don't want to throw them in the scanner. It's a lot harder to get a child to sit still for, however long that scan takes, 10 or 20 minutes. So like I said, ensuring to see that C7T1 level. Sometimes you can apply gentle traction on the shoulders if it's incomplete. Typically, if you're worried about it and you're at a trauma center, you're just going to get a CT scan. But if all you have are plain films, it is something to consider to rule. If you're trying to rule anything out, which is not a great test to rule it out, but it's all you have. Sometimes that's what you have to do, and that's especially if you're at roll 2, you guys have like a patient hold, and you have to hold them for 72 hours, like doing serial examinations on them, because you didn't have a CT scan to out the fracture, and you can't send them out. Allegedly they say the next war we have, we're not going to have all of our wonderful medevac assets. And then you can do a swimmer's view. This is like pretty old school, but it's still something that can be done. If you need to visualize that junction there, they can do swimmer's view where they have an arm up over the head. It's like old. This is like old school stuff. Did you guys have Dr. Castro during your lab? She's amazing. She was like taught here for like 30 years, but she's a surgeon. So she used to preach on these, but with the Advent CT, we're like, yeah, we don't do that very often. But it is something you can think about if you're stuck at that roll 2 and that's all you got. And like I said, there's that soft tissue edema we were talking about, 6 millimeters of C2. You want to look for any trachea narrowing, you want to look at the soft tissue. Like I said, any of that subcutaneous emphysema, free air. So that's another thing that this test can help you. Like if you're trying to decide whether you need to evac somebody out or not, all you have are those plain films at the roll 2. There's certainly a reasonable study that you can do and kind of evaluate. If you see any of those findings, like, okay, I got some soft tissue edema there, it's a little bit, a little bit wider, and I have some subcutaneous emphysema, I think there's something more going on, and so that can be a good screening test for you to send them out for further evaluation. So don't write off the plain films, but just remember, when hospital, you're going to order a CT scan to actually clear that C-spine and rule out any injuries. Then you're going to look at that lordotic curvature of the spine as well, and that'll help with like soft tissue swelling, especially muscle spasms. You can commonly see it, like that person looks like they have like a severe muscle spasm. That looks like a tetany patient or something there, but that's definitely indicative of like muscle spasm or losing that lordotic curvature. So that's something that you really need to pay attention to when you're evaluating patients with these plain films. Then we want to look at our ligaments in there. So we have our anterior ligament, and any sort of fracture can disrupt these ligaments because these ligaments provide stability in your spine. So any disruption of those ligaments, you're looking at that being unstable, and you can have like this one, you can have like protrusion of that vertebral body, which can then impinge on the spine. So it's important we understand these different ligaments we have in there and what we're looking for when we look at these images and what it can mean. Yep, and then you want to look at the posterior ligament and alignment. And then we have our AP view, which, the big thing's looking for symmetry. You want to check the pedicles on the vertebra, tracheal alignment, and then you can see those first 2 ribs, and then looking for any, subcutaneous air, making sure there's not no soft tissue edema there. You got your durodontoid view. So, the odontoid obviously provides that. It's essential for that pivotal rotation with C1, and it's the most significant component for lateral rotation. So any fracture to these can be pretty significant. We'll talk about it in the following slides. Typically, this is like most commonly seen in elderly patients that fall. We'll see a lot of these odontoid fractures. And we have different categorizations we use to decide whether we think they're stable and so whether they can heal on their own, whether they just need some sort of splinting or a collar. All right. Now we'll talk about all of our common injuries that can affect the C-spine, what's funny is we talk about a lot of them individually, but depending on what sort of the mechanism of injury, whether it was, a diving injury, hyperflexion, whether it was hyperextension, or a hangman's, a lot of these injuries, you'll have multiple levels of the C-spine is typically injured for those injuries, especially diving injuries. So we talk about them individually, but just remember you can have multiple fractures, like multiple of these at once when you have these injuries. That's why they're very significant when you get them. So our Jefferson fracture is an axial load. You typically see this a lot with like spearing of the helmet or the crown of the head. In football players, or generates an axial load and it transmits through the occipital condyles to the lateral masses at C1. So we typically call this a C1 burst fracture. And this one accounts for quite a bit of cervical spine fractures. The difficult part is they usually don't have any sort of neurologic deficit when we're evaluating these patients. So we need to make sure we're obviously immobilizing them and then evaluating for other concomitant fractures on these patients. But these ones are extremely unstable. They're going to have to see the spine surgeon. Then they'll make a decision on stability and whether they can do like halo vesta immobilization versus any sort of repair on these patients. And then we have different, because we can't make things easy, which is a straight axial load to the head, because it never works out perfectly in real life. So this just gives you a good indication of where that fracture might be, depending on where the axial load is placed. So if you're hitting them straight on, you get that burst fracture. And then you can get lateral fractures, anterior fractures, and posterior fractures, all depending on the position of their head and the axial load that was placed on top of it. So whether it was rotational or extended. So then you can just have different patterns of this, but the worst one is that burst fracture. Then we got our hangman's fracture, so that's traumatic spondylolisthesis of C2. And this obviously results usually from some sort of hanging injury or abrupt deceleration, and it creates bilateral fractures at the C2 pedals, resulting in usually an unstable fracture. Without the angulation, they may consider them stable. Either way, we have to, discuss with the neurosurgeon. They may get a Philadelphia collar or a SOMI brace. Did I show you guys a picture of that? I thought I had it on the slide last time. Maybe not. All right. So average healing time, just like any bone, is typically, this one's a little bit longer, 12 weeks. So, typically for most bones, you're like 6 to 12 weeks healing time for them. And you got your clay shoveler's fracture. This is a spinous process fracture. Typically we see it at C6 and C7. Isolated fractures are usually managed non-op, and they just place them in a rigid cervical collar until they can demonstrate healing and full range of motion. And this was commonly seen apparently with people shoveling clay, but we see it a lot with like construction workers and patients like that. Sometimes they might be struck on the back of the neck in that simple spot from a heavy piece of machinery. Then you get your like hyperflexion injuries. So these ones typically result from a blow to the occiput from below, and usually the initial disruptions in the posterior ligament complex, which leads to facet dislocation. So these ones can have significant like cord and root involvement. Like if it's unilateral, like half the patients will have a neurologic deficit, and if it's if it's bilateral, then 90% typically have some sort of neurologic deficit on exam. And then our teardrop fracture, which you can see in the picture there, is considered an unstable fracture. So the vertebra is usually displaced posteriorly, which can create like an anterior translation of that lower cord. So this often results in like quadriplegia. It's pretty bad or significant injury if you do see these. It's usually a poor outcome. Then we have our wonderful Asia impairment scale, and this is something you guys need to know. So this is just looking at central cord type injuries, or really any injury to that C-spine or the cord. And then we kind of base it on where it is, and then whether they have motor function, sensory function, whether one is preserved or one is not. So typically, like we have our A, which is a completely normal exam, or sorry, E is completely normal exam, then it goes in grade of severity, E, B, C, B, A. So D would be, they have motor function preserved below the level in at least half the muscle, so they'll usually have a muscle grade of 3 or more. So like if you have, their right lower extremity muscle grade is typically a 3 out of 5, and their upper extremity might be 5 out of 5. For Asia grade C, this one's going to be grade less than 3, so that's usually a lot more significant. So they might have like a 1 or 2 out of 3 on their motor grade. And then B is sensory, but motor function is preserved. And then A is motor and sensory is preserved, or not preserved, sorry. Oh, I had another. All right. Oh, it's on the slide after, never mind. All right, so we have our hyperextension injuries usually caused by a blow to the forehead. And it results in like a posterior complex fracture involving the anterior ligaments, as you kind of see how that's like retropulsed forward, which is causing significant impairment of that spinal column. And this is how these result in those different sorts of neurologic level losses that we're going to talk about with these like Brown-Séquard and our central cord syndromes. And then here's our different syndromes that we have for these injuries. So we have like our Brown-Séquard, and as you can see, it's kind of dark in where that injury is in that loss of function. And then they just kind of correlate with which one is associated with it. So like half of the spinal cord, typically from some sort of penetrating injury damaging it, they'll have its lateral paralysis with loss of touch and pressure, and then opposite contralateral loss of pain and temperature. And then we have our central cord, which is loss of motor, pain and temp perception below level. But typically for one of the ways for the central cord is they have greater lower extremity loss than upper extremity. And then we have like our central cord, which can be variable, and that's when we're using a lot of our different criteria there and grading where that location is. Then you have complete cord, which is everything. You're done. No bueno. And here's our old person fracture, like I was saying earlier, our odontoid fracture. So this is a C2 fracture. As you can see, the different types we have there. And most commonly, we're going to see that type 2 injury, and that's often in that elderly. It just falls on the ground level. They trip over something, they syncopize. And you'll have an odontoid fracture, typically the type 2, and these ones are going to still get, consulted with our neurosurgeon, and then they're going to decide on stability, on whether we can manage them non-operatively, which is what we like to do, especially in those elderly patients, just because they have lots of comorbidities. We don't want to surgerize every one of them. And yeah, I've never seen type 1. I've seen type 2 and 3 commonly with these ground level falls, but 1 is uncommon. Yeah. As you can see, lanto-occipital dislocations, they're rare, but they usually die immediately. I mean, look at how displaced that C-spine is. So as you can see, it usually causes significant brainstem injury leading to respiratory arrest and death. So we also have atlantoaxial dislocations, which usually are fatal as well, but all of them are highly unstable lesions, so we have to be very careful with these. And these are in these patients, we can typically put a C-collar on and apply traction, but these patients, traction is contraindicated, so we have to be very careful with these patients if we suspect this. All right. and here are just some other measures. You guys don't need to know these. These are just different intervals that the radiologist might use when they're reading those, or if you're reading them without a radiologist, that can help you for certain measurements and injuries. Like I said, other subtle indicators, if they're normal, you might want to think, hey, I need to do something a little more. If all you have are plain films, you may need to send them somewhere else or evacuate that patient. All right, moving into the L spine. So yes, some more A, B, C, D, E, Fs you guys need to know. Really, it's all, hopefully you guys have a systematic way you're looking at all of your imaging or your plain film, your CT scans. The mnemonics can help. Some people don't remember them, but like I don't remember mnemonics very well, but I have a systematic way that I look at all imaging. So I mean the alphabetical way is a very good mnemonic to use, but you're looking first off at alignment at the bones. You're looking for any sort of fractures, any loss of disc height. You're going to look at the pedicles, the processes, looking for any abnormality, signs of fracture. What do you guys see on this film here? Anything in the bones? I'm not seeing much in there. Maybe some signs of arthritis along the spine. That's about it. We also want to look for disc spacing as well, because that could be another subtle indicator that something's abnormal. And then you want to look for any sort of foreign bodies, any prosthetics, hardware that they may have in the spine. What's lovely, especially with like when you're CTing people and they don't tell you they got all this hardware, when you ask them about their past medical history, past surgical history, and they forget to mention that like half their spine's fused, and you're like, oh, that would be nice to know. But yeah, it's always something to consider when you may see some hardware or foreign bodies in there. So most of our L-spine fractures occur at that T12 to L1 junction, and most of them don't have any sort of neurologic deficit accompanying it. One of the things we can look at, like there are just different principles that can be used when we're evaluating for injuries. You guys don't need to memorize the dentist 3-column principle, but it's important to understand that if we break the spine down into 3 different columns and we look at those ligaments and what can be associated with it, we can help identify what type of fracture pattern they may have when we're evaluating these. We're going to talk about compression and burst, seatbelt fractures, chance fractures, are like a variant of a flexion distraction injury of the spine, and they're typically at that thoracolumbar junction. And these are ones that used to be more commonly seen, and they are still seen with the patients only wearing a lap belt, like in a motor vehicle crash. Those fractures are commonly seen with those. And we also see a lot of hollow viscous injury associated with those as well. So it's important we rule out any sort of other intra-abdominal pathology when we're evaluating these patients if we see this fracture. All right, so there's our compression fracture, as you can see by the positive arrow sign we have there. And we grade them like minimal to moderate. If it's less than 50% height and 30% angulation, with an intact posterior column, we typically just treat them non-operatively and with bed rest or activity modification and over-the-counter pain control. Now, if the loss of anterior height exceeds 50%, you have an increased risk of kyphosis, so those ones obviously need to be followed closely for monitoring the recovery, and if they're going to regain any of that disc height, or whether they need to follow up with the surgeon, so that we don't want to affect like their activities of daily living or anything like that. So it's important we evaluate those. We have our burst fractures. These are unstable. So as you can see by the pattern there, we have basically some sort of instability, whether it's anterior or posterior or bilateral or both. So typically this is going to have loss of over 50%. It's going to have retropulse fragments, which are narrowing the canal and increasing the risk for permanent disability in these patients. So that's why it's important. All of these ones have to have a neurosurgery consult for further evaluation, and we consider them unstable. And we have our TP fractures or transverse process fractures. These are common. What the important thing to remember with these, when you see an isolated one, you need to think about other injuries because the amount of trauma it takes. Like I think I just had one fell off a horse and they had a TB fracture, so I, wanted to make sure that they didn't have any other sort of like blunt, especially abdominal injuries, pelvic injuries. We need to think about where the amount of force it took to fracture those at that level. We need to make sure they don't have like associated pelvic fracture. They don't have any sort of, organ injury associated with this. So isolated, we typically don't do much for an isolated one, but we do need to ensure that we rule out all of those other life-threatening injuries that they can have going like this. All right. So, yeah, look, we don't have ABC mark for this one. That's good. So if we're looking at our pelvis, obviously we want to look at our iliac wings. We want to check our SI joints on there. We're looking at the pubic rami, the symphysis, acetabula, the femoral necks, and the proximal femur. Is everybody good with their anatomy on the pelvis and what all those are? Right? Yeah. Remember that? So these are going to be another common x-ray you guys are going to order and look at quite frequently. So it's important to understand all of these different structures and what sort of injuries we can have to them and what we consider unstable versus stable, and which ones are going to need to get further treatment. So here's some classifications we use. Why use one when we can use two? Is the way I like to look at it. Obviously, that's not how I thought when I was in PA school, though. So the first one, our young Burgess, is typically the one that, most commonly the one you guys have probably heard of, especially if you were anything prior medical, or if you went through like combat lifesaver and other things, they might talk about these different pelvic fractures. And really, mostly what we learn is put some sort of pelvic binder on them. But the young Burgess uses like whatever that vector is for the force, and that's typically where we see the fracture. So we got our lateral compression fracture on there. We got our vertical shear. And then we have our AP compression fracture. And then we use our AO tile classification, which just looks at the mechanical stability of the ring and where that's located. And we'll go over that on the next slides on how we classify those. But these are two common classifications we use. Typically, we use the young Burgess, but the orthopedic surgeons like to use a more complicated one, so that's why we also use the AO tile classification to better identify those fractures. So obviously, it's getting okay. So obviously it depends on the type of injury and what sort of trauma they had, mechanism. We want to look initially at the stability, right? Is the pelvis stable on our initial exam? And then based on our x-ray, we can classify what type of fracture that is. And as you can see in the pictures, where are the fractures in the top picture? You guys see both those on the rami? You got, one on your anterior rami on the right, and then on the left you have the posterior rami, which both of these are considered unstable. And then one, you have that on the right side, you have both rami on the same side fracture, which is considered unstable as well. So these are, just some different types of patterns we might see, but it's important to understand the anatomy and understand why these would be considered unstable. Obviously, the bottom one seems straightforward in my mind, and the top one as well, but any disruption in that entire pelvic ring can cause instability, which is why we like to classify these into different categories. Either way, the biggest concern here is stability of the patient initially. So unstable, they're going to need to go to the operating room no matter what type of fracture this is, so they can open them up and stop that bleed, because you can lose, anywhere from 3 to 4 liters in the pelvis, depending on what you read. Either way, that's over 50% of somebody's entire blood supply, so it's a pretty significant amount no matter how you slice it, which is why these can be such significant injuries. But our type A fractures, those ones are usually stable, and so they can be treated with just weight bearing as tolerated. Then we have our B1, which is an open book fracture, and so that's where we have that dislocation, the symphysis. You guys see, it obviously looks a lot wider than it normally would. So this is going to be are open book fractures, which they consider type B1. And then we have our type B2, which is lateral compression with minimal anterior dislocation. And some of these can be treated conservatively, some of them might require plate fixation, just depends on like how disruptive the symphysis is, whether there's an anterior like dislocation of it. And all of them are going to have some sort of orthopedic consult to determine what sort of treatment they're going to get. Then we have our type Cs. This is both anterior and posterior stabilization are required. So as you can see, it's pretty significant there. You have just lateral, like you have the SI joint there dislocated. You have multiple rami fractures on there. This one is pretty significant. So this one's going to need a plate fixation. This is one that typically can have a significant amount of associated bleeding with it, which is why we need to base our treatment on the patient's stability, whether they need to go straight to the OR versus whether we can get CT scans on these patients to identify a little bit more. It's also one, we need a pelvic binder, we need to get that EFAST exam on them in the trauma room. All right, take a 10-minute break, see you back at 11. We need to consider things when we have fractures of that pelvic ring. So, and obviously we have very important structures in that area, and one of them that can get injured is obviously our urethra and our bladder. So, like I kind of mentioned yesterday, we need to do a rectal exam on those patients. When we're looking for any like gross blood, we're also looking for a high riding prostate, which we talk about a lot. I've never felt one, but I think it's as we look at those and look at how they're displaced, I think it's a little difficult to tell an exam, but that is something. Maybe some of you guys will be like rectal exam experts, and you have, your fingers have better sensation than mine or something. You might find it, but anybody we suspect to have these injuries, especially with a pelvic fracture, prior to us putting any sort of Foley catheter in them, we need to do that retrograde urethrogram, and just to evaluate for any disruption that any of those bones or structures might have caused during that injury. It's also important to do a vaginal exam as well. And then as you can see on those images there, we have some abnormals on there where we see obviously contrast extravasation there. So we have some sort of injury or disruption. I'm trying to see the fractures on there. Oh yeah, okay. Yeah, so they have obviously pelvic fractures. You can visibly see on there. Then we need to look at our femoral necks, so our intracapsular fractures. So these ones are typically, they have that shortened, externally rotated, abducted lower extremity, so it's kind of sitting out and externally rotated. So these are indicative of those femoral neck fractures, and this is commonly seen in trauma patients, and once again, commonly seen in the elderly patients as well, especially those fall from standing patients. So we need to look at, obviously their age, comorbidities, and that can kind of help us determine whether we're suspecting one of those fractures. And obviously, it's portends a pretty poor outcome, especially in the elderly. I'm sure some of you have probably had grandparents die from this. These pelvic fractures, very common. And while the fracture may not kill them, usually the recovery eventually does. They succumb to these injuries. So it's very commonly seen in that elderly population, and we might see it in sort of blunt trauma or any other trauma as well. Then the belly. So this one's hard to diagnose anything on these plain films. There are subtle findings that we can look at. It's not like the chest X-ray where it can tell us a lot of great info, but there can be subtle findings, as you can kind of see with all these positive arrow signs. But once again, you can lose a lot of blood into the abdomen, which is why we need to worry about these injuries when we're evaluating them. So if all you have is a plain film, that might be what you use, but typically this one's going to be CT, abdomen, and pelvis with contrast. And then when we're looking at these, we want to look at our overall bowel gas patterns. Is there any air where it's not supposed to be? We got that extraluminal air. You will see calcifications. You'll commonly see phlebolus. And then you're looking for any soft tissue masses, so it's important to look at our spine as well, so you can see those like subtle indicators like TP fractures and other things in there. And then obviously any foreign bodies, any hardware. We may get a plain film if we're looking for like, you know, possibly gunshot wounds or blast injuries. A plain film can be helpful just to help identify where things are. And has anybody had to deal with that? Any sort of penetrating injuries? I forgot to mention that. A lot of times we'll place a radio opaque marker where that penetrating injury is on the skin when we get these plain films to help us better visualize what we're looking at so that we know that, okay, there's a penetrating injury there or a GSW stab wound. Or like, especially with, you know, blast injuries, multiple fragments, a lot of times, or shotguns, we'll place little radio opaque markers in that area. Sometimes we use something as simple as paper clips with a piece of tape, but they have actual markers that they make for the radiology techs that they place on there to help us better identify those. So we're looking, is there air in the stomach? Do we have adequate air throughout the small bowel? So typically we'll have, you know, air in 2 or 3 loops. We typically have air in the rectum. You know, you typically can't see the spleen or it's not well visualized, and a lot of the other structures aren't well visualized in there. So we base a lot of it on those different bowel gas patterns and what sort of shifting we might have in there. Like on that top right one, it looks like the spleen, looks like there's some sort of laceration or splenic injury that's pushing that gastric bubble towards the midline, which those are those subtle indicators you can see on plain films that may help clue you into what's going on and identifying whether you need a further workup. Typically, whether you need to evacuate them to get a CT scan. And then, like I said, always evaluate those transverse processes. So TP fractures can be an indication of severe trauma. Like I said, you can see if anybody that really like falls in, you know, abnormal angle, like I saw in like somebody bumped off a horse. You see it. Motorcycle riders. Sometimes you just see it falls off ladders, and that might be the only isolated injury. But you need to rule out everything else because obviously, you know, evaluating for any sort of intra-abdominal and thoracic pathology. And obviously extremity fractures, pelvic fractures, we need to make sure we do a thorough exam. That's all we find on here. And these will be something you guys see, because you'll have somebody that had some sort of fall and they'll come to sick call the next day, and all you'll see is a TP fracture. So that's why it's important you guys remember these things like, oh, I should probably get a CT. You know, the patient's stable, we walk into sick call, you know, we're giving them pain control or some sort of analgesics. We should probably rule out any other injuries in here, not just overlook it. The good news is most of our patient population is very young, healthy, mostly male population. So we kind of get away with doing negligent things sometimes, even though we don't really know that, we really don't think about it. Like that's one of the reasons when I went to do the EMED fellowship, I mean, all of us go through like, how did we not kill somebody? It's because they're like young, healthy, usually, you know, mostly male population. So we kind of get away with it, but these are subtle indicators. You guys see this, you know, you want to do further workup and evaluation on these patients. And obviously, yeah, that one's kind of obvious there. It looks like he took a shotgun to the belly. You can see all those fragments there. And this, like, you know, this is actually a tricky patient because the question is how deep are those? So obviously when you CT them, but if the patient's stable, sometimes, you know, they may not require surgery or they might require exploration to remove those. But I mean, just think of the damage you would do trying to remove all those pellets. So a lot of them we actually just let the body heal naturally, and those pellets will eventually fall out. Or BBs, whatever you want to call them. All right, so like we talked about before, you know, stable patient with positive FAST, we're going to get a CT. And we're looking, I mean, for everything, any sort of hollow disc injury, any extra contrast, any free air in the abdomen. The CT is a really good test that can help guide us in that stable patient. If they're unstable, they need to go to the OR. And then we look for any sort of like solid organ injury, any active bleeding. Sometimes we might get angiography on these patients as well, or CT angiogram. And like I said yesterday too, those hollow viscous injuries can be very tricky and kind of hide in that retroperitoneum a lot of the time. So we'll sometimes be able to identify those by other findings, like that free air, valve wall thickening, streaking, those subtle findings that aren't indicative of any one pathology, but they can help guide you to a further evaluation. All right, then we have all these wonderful extremity fractures. So we're not, we won't go over these, but you got, your transverse, oblique, spiral, comminuted. It's important to know what the management is for all of these, very commonly seen, especially in trauma. I see these, I worked last weekend and saw, a dozen fractures probably. Somebody cut his finger off with a machete, another one with a dumpster, so it's very common. And it sucks sewing fingers back on. It's a lot of work. But big considerations are whether this is an open versus a closed fracture when we're evaluating that trauma patient, and whether there's any associated bleeding. Obviously, those long bone fractures of the femur can lose a lot of blood with them. So we need to pay more attention to those, and then we also need to consider, like we talked about last lecture, compartment syndrome. Most commonly with those fib fractures, but you can see them in forearm fractures as well. So it is something we need to always think about when we're evaluating these patients. And then intracranial injury. So head CT is going to be the initial imaging test of choice. And like we talked about yesterday, what's that top left image? Epidural. What's the one on the right? Yeah, that's that subdural. Good. What about the one on the bottom left? C. Yep, subarachnoid, you got parenchymal. And then our FAST exam. So great, obviously bedside diagnostic tool we can use. Unfortunately, it doesn't give us an exact identification of where that injury is, but it is a great screening test to identify whether there's any bleeding or fluid in the belly, any free air, and can help us identify any sort of further injury. Obviously, it works really well in the pericardium as well. And then when we add EFAST to it, then we can look at the lungs for pneumothorax too. And here's some imaging. What do we see on this one? What's on that left? Left image, yeah, it's normal, good. And then you guys see that streak there on the right image? It's funny, I feel like every positive image we have that we like to use, especially on tests, are always grainy, poor quality images. You guys ever notice that? I'm just kidding. Kind of. All right, so here's our splenorenal fossa. And then obviously normal versus abnormal. Your guys' goal is to make your images and your windows look like these, okay? That was one of the things we noticed when we were grading, and it comes with time as you're doing a lot more FAST exams, which is why I would encourage you guys when you're in even your level 3 trauma centers or your lower level ones, that you're getting involved with the trauma, and even if they don't want you at the bedside, just chime in and say, hey, I can do the FAST, and they'll be like, oh, cool, we got somebody who can do something here. So just so you can get proficient at those images. Hopefully where you're going there in the emergency rooms, they'll usually give you guys classes on FAST exams. Some places, if you're lucky enough, will have an ultrasound fellowship in the ER, and they love to take on PA students and let you guys shadow them. Some of you will do your electives with ultrasound, which I think is a great elective for you guys to learn, especially because we're trying to push out ultrasound machines to every unit. So something I would definitely follow up on when you're at those facilities. I know Army has multiple facilities with ultrasound fellowships like Madigan, BAMC, Darnell, and I think Fort Bliss does as well. So those are good places to kind of get your foot in the door and They usually have like 2 fellows a year at most places, so they're happy to have you tag along with them. So it's something I would inquire about when you get to your phase 2, so you can get a little bit more proficient at these exams. And they work well for everything. I'm sure you guys learned it during your ultrasound classes, but like, you know, you can even evaluate fractures. Really great for soft tissue and derm complaints, which you guys will see a ton of. And it's also great for obviously that ocular complaint as well, which those are common conditions you guys are going to see like even in your field training. So when you do get ultrasounds in your units, it's important you guys are proficient at using them, okay? And then here's our suprapubic view or pouch Douglas. So, you know, we have our normal there, and then we have free fluid in those other images. And I'm sure that they talked about it. Sometimes a little bit of free fluid is physiologic and it is normal. So obviously you have to look at, you know, the right patient and the mechanism of injury and whether we think that's bleeding or not. And then there's our pericardium. So that's going to be that echo view, typically subxiphoid. You'll notice in some of the fluffier population we see nowadays, you might have to go with that parasternal long instead of the subxi, just because there's so much tissue in the way for you to adequately get that exam. Like a good rule of thumb, if you try your subxi once, just go for the parasternal long in an emergency. So that's typically my rule of thumb that I use. Or if they're just super fluffy, I just go straight to the parasternal long right off the bat because it's an emergency, you need to get that image. But as you can see on the one on the right, you've got free fluid around the heart, so that's going to be abnormal and concerning. So the next question is it, you know, is that causing symptoms? Is it symptomatic? Then we have to look at the right vent, look at the right vent adequately pumping, or is it collapsed? Then we have our pneumothorax, so obviously we've got, you know, our sand on the beach and our ocean. And we've got our barcode sign over there, and typically we'll, you know, we won't see those ants marching. Most of the time for, if we're going like at full speed for fast exams, we typically aren't going into the M mode there and looking at it like that. We're typically just looking for lung sliding on our initial look without going into the M mode or getting that sand on the beach sign. We typically, in a trauma patient, I don't know what, at least as I do it advancing, we usually do 3 levels of the ribs. So we start, you know, typically at the second up there. And then we just scan 3 ribs down for lung sliding. If we got it good, it takes like seconds, and then we do the same thing on the other side. So that's how a typical EFAST exam will go. And I mean, I think we are doing them in like 20 seconds. Start to finish, like under 30 for fast exams. It's also another adjunct we use when a patient's coding as well, and we're looking at cardiac activity. So we don't, when we do a rhythm, so whenever we're doing a rhythm check, a lot of times, you know, we'll throw a probe on there as well, or we're doing a pulse check. We'll throw a probe on, so you're looking at under 10 seconds because you don't want to stop, you know, discontinue CPR for longer than that. So you got to, you know, that's why it's important to get proficient at these exams and throw probes on everybody. All right, so I know there's a lot of imaging on there. You know, we covered basically the whole body. You know, I don't know. What do you guys think? Think it'd be helpful, like, to do more CTs on there? No? Or y'all probably aren't going to be reading a ton. Phase 2 you will. But once you're in clinic, you may not order as many CTs as you do, especially like in the ER. But it is important to understand for trauma. And like I said, when you're on your ER rotations, hold up every patient. I think every hospital has a PACS viewer in like wherever the doc box is or the team room is where all the providers are, where you guys will work. So just make sure you're pulling up all those images. If you're in phase 2 and you don't have like impacts access or the viewer access, you're probably wrong. Like you should get it. It's especially good for training, looking at every single image. But it's also fun in the ER pulling up every image they have on there and looking for any abnormalities, checking it with the report. When you guys get your phase 2, make sure you're asking people too, like, how do you read a CT? And actually having someone teach you with real patients, it's a lot better than looking at slides and talking about, you know, things we may never see. All right, what questions? Gotta have something, somebody gotta have one. Somebody make one up.